the care nearer to their homes. We can provide in-home support. We can provide more real-time and ready communication between the relevant clinician and the patient. We can help and inform carers in how they can support the expert patient as part of their overall care package. And I think developing services for people with long-term conditions is a fantastic example of a sustainable investment in the way in which we develop our services going forward. It improves the patient experience, it's much more convenient, the quality of care that the patient receives going forward is so much better, it takes unnecessary waste out of the system and provides an altogether more satisfactory, more resource-friendly and sustainable solution for the patient, for the staff providing the care, for the system as a whole. And I think that when we can talk about sustainability in those terms, in the language of real services for patients, then it's a compelling, absolutely compelling priority that we can all line up behind, support and put our energies into taking forward. Certainly, if we think about yesterday's discussion in the House of Commons, the first reading of the bill, the scale of challenge going forward that we face was starkly laid out for us. The potential that the reforms give us to really drive benefits for patients in a sustainable way is all laid out there in the health bill. And right now we face the combination of needing to continue to drive up the quality in service, needing to be more productive in this tighter economic environment. And Neil and I, reflecting at the time that he was suggesting we take one or two of these pictures off the wall, was that we, in this generation, which we might get to, in this generation, he might do well, I hold the ladder. In this generation of management that we're all in, we haven't faced as tough a time in the economic climate going forward as we face now.
Neil, how important do you think the route map is going to be for the NHS?
I think over the last couple of years we've made remarkable strides in terms of trying to persuade people to take this whole agenda of sustainability seriously. Carbon reduction strategy was a really important first step in that drive, but we've got to get beyond simply reducing carbon emissions, and we've got to get people to appreciate that the concept of sustainability is part of the solution, is part of the way in which we ought to do business, and it will help us make sure that we improve the quality of healthcare for which we have responsibility.
And how do you think this is going to be implemented?
We have to, as we've been hearing in this conference this morning, we have to get people and organisations to believe this is part of the solution. I think we are making progress. We need to get boards to take it more seriously. There's a big coalition of support getting behind this with managers, politicians, Sir David Nicholson in the Department of Health, professional organisations, the BMA, the RCN, the Royal Colleges. There's a big coalition getting behind this, and I think that's the way in which we get the message across and get people to take it seriously.
How do you think we'd be able to end up implementing the route map for the NHS?
Well, of course, it's not our job to implement the route map for the NHS. It's our job to offer the route map as a common framework for action across the NHS in England, but also for partners, for other health systems around the world, and to really make sense of a lot of activity that's going on, but maybe activity that's possibly uncoordinated and unsystematic. So the real point of the route map is to bring order to a mass of commitment and enthusiasm.
Do you think the NHS could ever be truly sustainable? I mean, it's so massive. Do you think we could ever coordinate, or so many people could ever coordinate to actually do something that positive?
Well, it depends what we mean by truly sustainable. Don't forget, if you just talk about the carbon element of sustainability, we all have a carbon allowance. I mean, we may be using 3 times our carbon allowance, but in terms of making it sustainable, if the question is, can we provide high quality healthcare in perpetuity within the resources we've got? Yes, we can. There's no doubt we can. We're not doing it at the moment. We can do it. There are some things we don't know how to do, but it's not beyond our wit to find out what the ways that there are of doing it. So yes, we can provide healthcare sustainably.
What do you think is going to make the biggest sort of seismic shift in actually getting the NHS to reduce its carbon footprint?
I think there are two possible seismic shifts. I mean, the future may prove me wrong, but the two seismic shifts I think are not only important but necessary. One is a public willingness to see this happen. Without the public, we can do nothing. With them, we can do almost everything. But the other is a true economic costing of the resources we use and the carbon we generate. If they were properly costed and properly valued, we'd move towards that sustainable health service even more quickly.
Apologies to you, you've heard this metaphor before. My GP trainer called Brian Clark, he worked in Caen, and he used to say, life is a ball of shit, and our job is to direct people to the shallow end. Which you can have as a motto if you want to, I sense it might not be politically correct. But I sort of developed the metaphor, and I always think of working in healthcare as a bit being like camping along beside the banks of a river, and all these bodies come floating down, and increasingly we dive deep, deep, deep into the river, and we pull out people who are sicker and sicker and sicker. We spend an absolute fortune trying to put them back together again, but we don't have time to wander upstream and look at who's pushing them in. And in my mind, that prevention thing, stopping people falling in the first place, is absolutely crucial. Occasionally I go into hospitals still as a GP, and I walk around and I walk onto intensive care, and I see people in their 90s having their lives slowly sucked out of them on ventilators, thinking, what are we doing? We're still spending a huge amount of money at end-of-life care. Do we have the skill set to have this really difficult discussion about end-of-life care, which is where a lot of the money seems to go? General practice has probably only changed really significantly since I joined it in the level of computerisation. We're talking about using technology. We're pretty much entirely dependent on computers now. I mean, we're set little targets, we tick our boxes, and the repeat prescriptions come out. I generally do Tuesdays. There's this huge pile of repeat prescriptions. Half the patients I've never met, half the drugs I've never heard of, to be honest. The only thing that keeps it safe is the computer. The only thing that spots these dangerous drug interactions is the computer. We're almost entirely reliant on it for safety reasons. If you ever go into your GP practice and they say, the computers are down, get the hell out of there now. It's the most dangerous place on earth for general practice with the computers down. But we sort of half missed a trick. We sussed out in general practice that if you take a computer system that you get on with and you train yourself locally, and you get the bit that's fit for purpose, that's how you use technology. It's quite interesting that I have really high expectations for the NHS computer program, because if we could actually work and share information, I would know where my patients are up in casualty, I would know across boundaries, across silos where my patients were. It would make a huge difference in mapping the patient journey. But what we learned about technology is it can't be centrally imposed. Healthcare and technology are actually very similar. They're complex organisms, almost like a pigeon. And too much in healthcare, we treat things as targets. We treat little blocks as if they're bricks. And if you throw your brick out of the window of the Department of Health with a certain force, a certain trajectory, in a linear system, you know precisely where your brick is going to land. But unfortunately, healthcare and technology are pigeons. If you set your pigeon free from the window of the Department of Health, you have no idea where it's going to land. So the only way to make this work is to collaborate locally. Health and social care and transport and education and police and schools. You all get together and you decide exactly where you want your pigeon to land. You collaborate. And then when you decide, you put a bit of birdseed there, bit of birdseed there, bit of birdseed there, bit of birdseed there. Unfortunately, the political way of getting the pigeon to land where you want to do is tying a brick to it before you throw it out of the window. So it's not just about the technology, it's how we use the technology, and we use the technology by collaborating locally. I'd like to be an optimist, because I think if any group of people get this in terms of